And now we are jumping on pitch speeches. And the first pitch speech we have digital health and personalized screening for early detection of diseases. Mr. Ronald Zwartkris, International Partnership Lead Public Health, Topicus. Well, the floor is yours and we are happy to have you here on the first pitch in the second part of the day. Hello.
Thank you very much. Let me first. So, can everyone hear me? Yes.
Yes, we hear you well and we see also a presentation.
Very good. Thank you very much. Good afternoon, ladies and gentlemen. I am Ronald Zwartkris, International Partnership Lead Public Health at Topicus. And during this session, I would like to give you a bit more information about the early detection of diseases via personalized screening. First of all, about Topicus, we are one of the largest software companies in the Netherlands with 1,100 professionals with a focus on healthcare, education, finance, and governmental services. And I work as an international business developer at the business line Public Health. And in our vision, health should be accessible, efficient, and the right technology should be used. In this, using interoperability standards and optimizing digital health has our main focus. In our mission, we formulated a so-called BHAG, which is a big, hairy, audacious goal, which states that by 2030, we have screened 100 million people, referring them to the right healthcare professionals. Currently, we already support screening of millions of Dutch citizens yearly, so we know that goal is within our reach. At the core of screening citizens, there is two ways to do that. So there is opportunistic screening and there is organized screening. And in an organized screening program, all eligible citizens are invited to take part of the screening, whereas opportunistic screening supports only citizens who ask for it and or when citizens are already in touch with healthcare professionals like a general practitioner. In the Netherlands, we have a long-standing history of cancer screening, and as you can see here, the numbers are quite impressive. We screen millions and millions of people per year. The figures you see here are from 2019. It's a sum from breast cancer, colorectal cancer, and cervical cancer screening. Well, as not all of you are aware of what the screening process, screening pathway is all about, here you see the screening pathway showing the different components. So out of a population as a whole, people are selected according to the screening protocol, which is basically based upon sex and age cohorts. And they get an invitation, they take part of the screening process itself by mammography, and that is for breast cancer screening, by a self-sampling fit test for colorectal cancer screening, and a pap smear at the GP or a self-sampling high-risk HPV sampling kit for cervical cancer screening. In case of a negative result, participants re-enter the screening cycle, and in case of a positive result, further investigation is being done and a diagnosis will be made. Well, some unfortunate people will have to be treated at a healthcare provider, which is hopefully a personal medicine approach like the previous speaker. So personalized screening, what is it all about? It consists of three dimensions. So first of all, risk factors, two, data from the screening rounds itself, and three, individual preferences from participants. Risk factors include, amongst others, medical and family history, lifestyle, and genomics, like already said in a couple of speeches before. And the purpose of screening is that there is a better balance between the benefits, so which is lower mortality and morbidity, harms, well, like false positives and overdiagnosis, and costs. So that is a value-based healthcare approach. And apart from that, a side effect could or should be a higher participation rate. Then a few components from personalized. So before the screening process starts, raising awareness is important for the recruitment of participants in a personalized manner. This could be done via social media channels, like in this example of a WHO Facebook ad on the left-hand side of the screen, to raise awareness for the importance of vaccination to prevent women from getting cervical cancer. Apart from social media channels like Facebook and Instagram, contact moments at your GP can be used for, like example, a Dutch digital patient platform, spreekuur.nl, but as well as patient engagement platforms like screening.lv, as you can see in a screenshot on the bottom end, from the great Latvian software company Longgenesis, as also previously already was speaking during the summit. Then in respect to selection and invitation, apart from the selection process, which could be risk-based, it should be risk-based, we think positive experience have been reported in the UK during the invitation process with sending explicit enhancement letters to participants, which increased the overall participation rate with 7% and also reducing the difference in response between low and high socioeconomic groups. Here you see the way this is done in the UK. And then the screening process itself. In this process, breast cancer screening can be supported with AI to detect high-risk women so that they will get an MRI, for example, or ultrasound. We do see that self-sampling kits for women to detect high-risk HPV can be used in cervical cancer screening, and for colorectal cancer screening, we see that hemoglobin values itself can be used for using in following screening rounds. How do we see the future of personalized screening? Well, one of the most promising developments would be to extend screening with intervals of participants with a negative screening result, where no abnormalities are found, and decreasing screening intervals of women at high risk. Doing so, we reduce the number of screenings for the vast majority of people. For AI as a decision support, we will partner up with the Dutch AI software company ScreenPoint, and with this also, this will reduce the working load of radiologists, which are healthcare professionals pretty rare in a lot of countries. Actively contributing to risk stratification in cancer screening is the other development we like to support. And in 2022, we hope to contribute to the personalized colorectal cancer screening program together with Erasmus Medical Center. More in general, we would also like to support the Latvia community, of course, with population health management, hopefully together with Longgenesis. I thank you very much for your attention and happy to answer any questions today. And you can reach out per email to me. Thank you very much.
Thank you very much, Ronald. In Latvia, screening is, as most probably in other countries too, a very important issue, and there's a lot of discussions how to organize also proper screenings already on a decision-making level. The question is, what would be your advice, maybe from personal experience out of particular project, but looking on the screening process at all, what was, in your experience, the best qualitative jump in some screening campaign? You started something new and you said, whoa, that works really very well. I was not thinking that that's going to work so well. Maybe you can from personal perspective, share the good memories of some screening method that started to work very well.
It's for internationalization. It's at pretty early stages, but what I do think is that the commitment from healthcare insurers is very important. Like in Colombia, we have a pilot on cervical cancer screening, and there we built the business case around cancer screening, and then Erasmus Medical Center helped us with making it clear that there is less screening involved, there are less laboratory lab tests, there is less colposcopy. So there are different variables which overall says, okay, screening doesn't have to be very costly. So I think our conversations with healthcare insurers, also in Indonesia, for example, have done a lot of good work. And I think in the Netherlands, there is a lot of awareness raising already. We have this long history in cancer screening, and there is a lot of trust. And we have the help of a very good medical center, Erasmus. So these are some components we see.
Thank you very much for sharing your experience and this extremely valuable, in fact, information when we are here in Latvia also premeditating and meditating on the screening options. Thank you very much. We are switching over to the next pitch of ours. Artificial intelligence again comes into the game. Artificial intelligence adaptation in Latvian healthcare system. And I already see with my right eye from this side, with my right eye, Kaspars Gross, Customer Relation and Business Development Manager, DataMed. The floor is yours.
Thank you so much. Thank you so much, and hello everybody. My name is Kaspars, and from DataMed. Well, I don't think that anybody has a lot of questions regarding AI. Everybody knows what is AI, and actually today I'm going to dig a bit deeper what we do in Latvia and what we are able to do in Latvia already now and what we are doing right now. So AI in healthcare, there are a lot of domains, as you can see on the screen. So we can start with big data, surgery, diagnostics. Everywhere AI is helping, and I'm pretty convinced that everybody of you who are here participating or who are seeing this on your computer screens, you have been interacting with some kind of AI today, yesterday, and 2 minutes ago. Maybe even you don't know it. Right? The same applies in healthcare, and in healthcare we are working here in Latvia together right now with three companies. I will tell you a bit more about two. So we are working with a French company called Gleamer, and Gleamer is number one, I would say, AI-powered trauma patients algorithm who can diagnose different kind of traumas. So we can help a lot in emergency care, in pediatrics. So currently we are deployed in 3 hospitals in Latvia, and 2 of them are rural hospitals where there are lack of pediatricians, lack of radiologists sometimes, and traumatologists, and AI can actually help to do the job much more faster, with less mistakes and with faster outcomes. The other company is called Lunit we are talking about and we are working with, and Lunit have also 2 different projects. So one is mammography screening, and they did research on mammography screenings, and they did research on how effective is mammography after mammography screening, the checking of mammography pictures. So from you can see the blue line is a general radiologist, so, and his performance. The red line is when breast specialist is looking at the same pictures, and the black line is AI alone. So, and when they compared it together and took it all together and gave those 2 specialists AI, we can see that performance levels increased a lot. Right, for both for general radiologists and also for breast specialists. So what does it mean? It means that in closest time we don't see, and we are pretty sure that AI won't replace any radiologist or any specialist, because as it was said in the previous pitches, that cure is coming from doctor, right? So, or treatment is coming from doctor, not from AI. AI will help to diagnose it much more better, much more faster, and it is doing it right now. So the few case studies regarding mammography screening and the things what we can do right now and what we could do already yesterday. So we can, for example, do whole mammography Latvian screening with today's data and with previous year's data. So here you can see that one of the breast cancers was diagnosed in 2010, for example, and then manufacturers took those images from the previous years, and we can see that actually the diagnosis was already seen by algorithm 3 years before. So with quite high abnormality score, which is 71%, that it's pretty sure that there was a tumor at that point of time already, and it could be diagnosed 3 years in advance. So the same applies for chest X-rays, which is normally a random check before you go to work at some place or something, you can get a normal chest X-ray. And also here the use case is that in 2016 the diagnosis of lung cancer was diagnosed 4 years in advance with AI. So taking this to account, we can also help with COVID patients. Lunit have a white paper on this and posts in the journal, which I can share later on and which can be seen afterwards in the side notes here. And we can do it and implement it in Latvia already yesterday. The last but not the least thing, what are the bottlenecks? Maybe that's more for guys who will speak here on the stage later on. So first is a lot of talk about today is about trust, right? So trust is very big issue, and trust in information which we have regarding AI, trust in education and maybe this education and knowledge about AI and about buzz, which is which and which is good and which is not good is not enough in this space. There are some regulation problems or there are almost no regulations regarding AI and diagnostics. So lack of information and in innovation domain in healthcare authorities, I think, and there has been great job done with the health ministry and NHS. But still, I think that this conversation can be much more better, and we can do it much more better just talking and sharing those things. What can private sector help, and how can private sector do, and what government can do, and help to implement these innovations much more faster, like our neighbors do, for example. And of course, use of innovations in national level. So we need more, and I'm pretty convinced that we will have soon enough sandboxes and test beds for hospitals and for this field, and access to specialists and decision makers to address innovations in national level. Thank you so much. That's all for me. Hope to get this clearer. Maybe some questions.
Thank you. Thank you very much, Kaspars. There's a lot of themes that we are discussing here today. This will be a provocative question, in fact. If you would have ability to focus some state investment to some kind of field in healthcare, where it should go to increase the efficiency in the topic you're speaking about, artificial intelligence and possibilities to enhance the skills of doctors, possibilities of doctors through artificial intelligence. If I would give you $1 million, where are you going to put it? That's my question.
Well, definitely, we need to look at more than one factor here, right? So first of all, is shortage of physicians and shortage of, for example, radiologists. So currently, AI is the most advanced, I would say, in imaging recognition. So I would put all my money right now on that, because imaging and imaging diagnostics is one of the fields which are most promising and most fastly growing, right? Because the amount of image will increase because the cost is going down. And if you add AI there, so we eliminate, I don't know, satisfaction biases. We eliminate different kind of like things that somebody is tired from the party or not maybe party, but from long hours working with patients and so on, so on. So this is like a help across. It's not only one thing or one place to put it, but I think that currently my cards would be on diagnostics and imaging.
Wonderful. Thank you very much. And I believe it's 1 million. That's just the seed money from the beginning. In fact, you need much more.
It's not so expensive.
Thank you. Thank you very much. Yes, indeed. On the issue of expenses, we're also going to discuss in the panel discussion innovations and that Quality, in fact, costs money, and at the beginning it can be challenging to understand why it is so expensive, but at the end of the day it pays definitely off. That's for the panel discussion. Our next pitch speaker also here on the stage. My pleasure to invite Marina Petrakova, founder and CEO of VR Each, helping children to access sustainable continuous rehabilitation in virtual reality. The floor is yours.
Thank you so much. I'm very happy to introduce you to our solution, which help children to access sustainable and measurable rehabilitation in virtual reality. My name is Marina, and I am CEO and co-founder of VReach. There is a fact that children disability increasing and actually for now we know that there are more than 7,000 children with disabilities aged from 0 to 18 years old. And also we know that yearly income also is growing, and for now in 2020 more than 300 children with disability got their diagnosis, and it came from more than 500,000 functional diagnostics examination made by more than 1,000 specialists who are making diagnosing and assessment of different conditions. And if we take in account and see how does it look like patient profile, we know that it can be a girl, 10 years old, her name maybe is Laina, and she has several diagnoses, including maybe autistic spectrum disorder, mixed receptive expressive language disorder, and so on. And she needs to receive, and actually she receives, functional therapy more than 4 times per week. She was diagnosed in her 8 years old, and it was because of lack of connection. Family found a specialist after years of trying. So if we take a look into patient journey and patient-Medicare interaction, it should be that, first of all, we start with the first consultation made by doctor. Afterwards, we bring functional specialists who assess and make early diagnostics and prevention, as well as they provide short-term or long-term course of rehabilitation and the functional trainings, a patient-centered service, and of course measure the results, measure the processes, and delivers continuous monitoring of the condition of the child. But what we discovered that there is lack of tools, lack of data, and that's why between first consultation and diagnostics, either therapy, there are years. And what we actually discovered that time and tools, it's money, there is straight connection between quality of rehabilitation and resources. So patient-centered therapy design is what we help to conduct, a fully controlled experience, making real trust and connection between all of the specialists, parents and children. So our solution is VReach, which helps the mind with the power of VR, totally safe and fully controlled. And it consists from 3 parts, from specific VR experience, specific UI for performance tracking, as well as for of application, which is used by functional specialists, saving time and money, as well as they conduct the therapy via application, as well as we have data from virtual reality obtained and used to measure the progress regarding therapy goals. So this is a tool which highly in real-time customized environment which saves time, resources, bringing transparency to all participants, and also it's 13 targeted programs to develop different skills in the children. And we don't change only experience of patients, of children, we also transform specialist experience by bringing resources efficacy, transparency, condition monitoring, because if we take into account that children are different, they need personalized approach and they need multidisciplinary team to receive rehabilitation. Condition monitoring is a must, and objective data from VR, which we also conduct, helps to assess and make a decision on therapy strategy. So what we also do, we deliver not also to the clinics and to the specialists our solution, but also we deliver this to the families, and more than 800 sessions already conducted with the VReach, and children and their families can receive continuous rehabilitation fully remote wherever they are. And VReach is the essential and really accessible tool for continuous children rehabilitation, especially in COVID-19 pandemic times. And we have proven this, and what we would like to highlight, I would like to highlight that ethical use of technology. It means that new generation of medical specialists who are open-minded and they need support in use of technology, so we provide that support. As well as monitoring and measuring the progress is a key to results and to success, because if we take into account child with autistic spectrum disorder, it's a one condition, and if we take into account child with a cerebral palsy, it's totally different, and the progress can be different. So we need to understand on what kind of data we make diagnosis and the therapy strategy. As well as we know that families and specialists are ready to commit their time, their input into long-term therapy, which can be years, and also buy virtual reality equipment. So we see that it is potentially a huge solution for all of the industry. And we developed the framework which allows to help specialists overcome very different boundaries and daily challenges, such as lack of connection with the patients, material lack, and so on. So challenges which we faced, and about what I would like to mention, that patient experience is a must, especially when we talk about functional rehabilitation of skills of children. And the use of objective data in decision making is a must, because we have to deliver the most amazing results. As well as transparency and engagement can be built only on trustful data. As well as initial funding for research and development, for validation and testing such solutions can significantly improve the time when this solution is delivered to the market and to the users. So it would be amazing if we as industry, as ecosystem would have opportunity to see much more solutions like VReach. And also there is a challenge, support gap between management and specialists, but we as ecosystem, as industry, we can overcome this by having dialogue and seeing the strategies how we can support each other. And during this year, we have proven that access, the new experience can be trustful, can be easy, can be pleasant, and it should be like this in children rehabilitation. I would be happy to answer all your questions, and let's talk. My name was Marina, and is Marina, and I'm from VReach. Thank you.
Thank you very much. Marina, you answered my question. You have a very wise title of the company. We reach, we are each, as for each, very nice, very good. So we reach is the title of company. My question is, you mentioned very important issues like patient in the center of everything, ethical approach, which can be taken over to the all technological process. Here, precisely, the question is about open-mindedness of patients toward technology, because you mentioned that young doctors should be open-minded, but what about patients? Are they open-minded for solutions which are new, fresh, unrecognizable, because absolutely innovative? What's your experience with the open-mindedness of patients? Yes.
I believe that if we talk about patient engagement, we understand that our patients are quite small, from 0 to 18 years old, and they have different spontaneous limitations, and they can't really receive the therapy as it's supposed to be for adults with neurotypical development. So what we designed a solution which attracts attention, which brings something very interesting, which takes the child and brings to the environment where he feels very engaged, very safe, and specialist at that time knows how to lead this collaboration. So when we talk about technology and innovation, it's always led of functional specialist who is delivering this. And yeah, if I can say thank you so much to all of the specialists who use our technology, I should do this because it's incredible, open-minded and wise collaboration, in my opinion.
Thank you. Thank you very much for this pitch. Marina Petrakova from We Reach. And we are going further on the next pitch. Also the patient in the center, better patient health outcomes without spending more, which is extremely important topic to speak about. Kristaps Krafte, Vigo Health. Kristaps, the floor is yours.
Hi, everybody. I'm super happy to be here this year on the other side of the screen. Thank you very much for the introduction, Martinša. It's a pleasure to be here, and my presentation is going to be about Vigo Health and how we can help the healthcare systems to do a better job of taking care of the patients. So let me share my screen. In just a second to make the presentation work. All right. So, Vigo is empowering stroke patients to recover after stroke. And my background is from healthcare. I come from a study program called Innovation in Healthcare. It's not a clinical healthcare degree, but it's an organizational or operational degree with a lot of focus on innovation. And this was when I lived back in Copenhagen and in Rotterdam in Netherlands. So I'm very happy to bring the experience that I gained in those schools back to Latvia. I moved back to my home country a bit more than 2 years ago to start Vigo. So we work in stroke, and stroke is the leading cause of death and long-term disability worldwide. It's a huge problem, and a lot of money is spent on this. 34% of all healthcare costs are spent on stroke and stroke care. That's a huge burden to families and the healthcare systems all over the world, certainly in Latvia, but in in all the places around the world. Only 10% of stroke survivors recover entirely. This is a very small number, knowing how much we spend. And that means that there is lost workforce, there is economic burden on the government, on the healthcare system side, and there's also a burden to families, of course. Vigo is a digital therapeutic for stroke rehabilitation, delivering patient-centered care through the ease of an app. That is available 24 hours a day, wherever the patient is, and for as long as they need it. And this is Vigo, you can see on your screens. We deliver everything the stroke patients need in their recovery journey, starting from functional therapy, speech and language therapy, cognitive training, occupational therapy, cognitive behavioral therapy, and patient education. We try to deliver everything that patient and the family needs to recover in their own homes. Vigo is not for every stroke survivor, but for the majority of stroke survivors, Vigo can help so much. It has also helped my grandma to recover from stroke. And Vigo solves 3 challenges that all healthcare systems faces, but we definitely solve. But that we definitely solve also with Vigo. So that is providing quality care to everyone in need, and not only quality care. We provide measurable care, measurable quality of care, and also consistent quality. Consistent quality is oftentimes an issue in healthcare systems because with so many institutions, with so many specialists, the quality very often varies. So with Vigo, we can provide consistent quality. We can mitigate medical staff workload, and very often people that are admitted to hospitals and rehabilitation centers. For example, our main partner in development is Vaiva Rehabilitation Center. We know that they very often receive cases that could be treated at home, but that are admitted to the rehabilitation center, but there's simply and then the staff don't take care of the very, very ill patients, but instead takes care of the patients that could easily recover at home. And we also at Vigo shorten patient stays to decrease hospital load. These are challenges that not only Vigo solves, but that are also amplified by the crisis of the COVID-19. And yes, COVID-19 is crisis, and it's definitely a big challenge to healthcare systems all over the world. But the sooner we start to implement the learnings from the crisis, the sooner we will get, the sooner we will make it an opportunity for us. Because yes, it is a crisis, but it's also a huge opportunity for us to implement changes that will help not only to recover from COVID-19, but that will also help us in the long term, that will make healthcare more efficient for the long term, not only solving the very urgent challenges. And that is focusing on value-based healthcare, focusing on digital solutions that can save cost and improve outcomes. And we can certainly do that with Vigo, but there's many solutions. Also what Marina previously talked about and what Kaspars previously talked about, there are many digital solutions out there that can make, that can help the health systems to work more effectively. And I really urge everyone here, but more specifically the government or the governing bodies of health system in Latvia and all over the world, for a matter of fact, sit down with the industry, sit down with people that are really innovating, and make these solutions available for patients faster. We know we can help. We just need a little push from the government, from the governing bodies, and even a little bigger push from the government bodies, because we're already almost there. But we need a little more help to altogether help patients more effectively. Thank you very much. My time is up. I'll be happy to answer some questions and also join later in the panel discussion. Thank you.
Yes. Thank you indeed, Kristaps. You will participate in the panel discussion, and there we're going to open up in depth the question and the issues you mentioned. My quick question and tricky question, in fact, is you share experience from as we say, foreign countries, studying there and getting knowledge. And then you were trying to innovate here in Latvia and push your product within Latvia, within the system. The tricky question is, which part of ecosystem we are speaking here about was most conservative from your perspective? Be careful with the answer, because you have to continue to deliver the Vigo Health. But still, where is conservative minds located in the ecosystem which are not so open for innovation?
Sure. I don't want to say that Latvia is very different from other countries where I lived and studied or worked in healthcare systems. Latvia is very similar in that regard, and all of those healthcare systems in every country are more or less conservative. It is one of the more conservative industries out there, no matter where we are. But we see kind of, with these digital solutions, we see pushback from maybe I would mention two places, and I'm not scared of mentioning them. It's a fact, but older generation doctors don't usually believe that digital solutions can help. And the other pushback we also get is from the health system and maybe from the more operational side of the health system, from some clerks in lower mid-level positions in the healthcare system that also don't perhaps recognize or haven't heard of digital solutions making change. But I want to ensure, if you guys are listening, we really can make the difference. There are clinical studies made, and we're actually we have run a clinical trial on Vigo, or a feasibility trial on Vigo last year with the Riga Student University, and we're launching one in a week with Riga Student University, a randomized control trial. So please reach out to me if you want to find out more how these solutions can help, because we know we can deliver.
Thank you very much for your knowledge, for your activity, and of course for enthusiasm you are bringing into the field, which matters very much. Thank you very much, and seeing Kristaps in the panel discussion. Our next pitch is going to augmented reality in a healthcare. About augmented, the word augmented was used today a lot. In fact, saying that that's the real word we should use at all, not saying that there is artificial intelligence, but augmented intelligence. In this case, what really means augmented reality in healthcare, Madara Kalniņa-Kalnmale, CEO, Lightspace Technologies. Absolutely happy to have you here, Madara. The floor is yours.
Thank you. Right. Good afternoon, everyone. It's my pleasure to be here and represent company, Lightspace Technologies. And Lightspace, based on its proprietary technology has developed something really unique. It's the world's first augmented reality headset, which is able to reconstruct real 3D just in front of you in up to the smallest detail. And a bit about augmented reality. Of course, you all have heard about VR, AR solutions, mostly in gaming, of course. And there was the promise already 6-7 years back that every surgeon will use augmented reality glasses to guide the surgery process, to make less invasive procedure, to reduce the human error factor, and yes, overall to reduce the operating time. But the reality, unfortunately, is on your right side. And where is the problem? Yeah. Currently, all existing AR, VR technologies are based on single focal plane, and due to that fact, it is impossible to perform precise activities at close distance, because everything closer than 2-meter distance is out of focus. It is impossible to see highly detailed image just in front of you. So imagine surgeon cannot perform surgery if he or she cannot see visualization just in front of. So, and another very important factor is that after 10 to 15 minutes, you will start to feel dizziness, eye strain, somebody feels headaches. So this technology, this uptake of the technology is greatly hindered due to this fact. So what Lightspace has done differently is its own proprietary multifocal approach, based on which we have developed a headset, which we love to call optical reality headset, to be used in operating room to guide the surgeon during the procedure, and also which can be used in pre-procedural process to plan the surgery. In a such form factor, the product will be launched early next year, and we have already started the first partnerships with partners who are those who develop medical grade content and applications for our hardware. As I already mentioned, based on our proprietary technology and fully manufactured in-house in our liquid crystal fab, this product can be used together with main 3D data sets which come from MRI, CT, PET, or other scans, which give us a 3D information. And in such way, we are able to show you content just in front of you, cross sections. And this is an amazing tool for surgeons how to plan the surgery, and actually also as a visual guide during the surgery. So applications in medicine, not only, also we are aiming to be used in medical training and education, of course. And the headset, this is the very first prototype already, I think 2 years back, was demonstrated in local hospitals, while our headset has traveled a lot and has been evaluated and tested in such a huge health tech companies as Smith & Nephew, Medtronic, Stryker, just to name few of them. And the plan is to start the cooperation with a few large companies in healthcare to actually build a real application based on our headset, where it brings the biggest value. And it is our possibility to show you a real 3D with whole field of depth, and in such way it really can be used in cranial surgeries. It gives a really added value for spine surgeries, as a pedicle screw placement, just to name few of applications where we are working on. Another comment also, which Marina, something similar as Marina mentioned, is also we are looking at children treatment, and more specifically it's amblyopia, or so-called lazy eye, where multifocal approach could be used to treat amblyopia, to train the lazy eye. Well, this is about Lightspace and how it can be used in healthcare, and company is very open for strategic collaboration, and all content, medical content and application providers are very welcome to contact us. We are engaging with all kind of companies right now to make it happen, and of course it all it all made happen due to this amazing team which we have. We are 64 in total, and including optics, electronics, mechanics, engineers. We made it happen. So that's who we are, and seeing is believing, as I always like to say, and you simply have to see it to believe that we are able to provide a real 3D just in front of you. Thank you a lot, and I'm ready to answer all the questions raised.
Thank you very much. Seeing is believing, and I also have a question, or to be more precise, our audience has a question, which is based on values and on beliefs. This is the panel where we're speaking about innovations, and in fact, innovations in Latvia particularly. So what is your opinion, why it is worth to start innovation business here in Latvia? Maybe that's kind of inspirational answer audience is waiting from you.
I think, is sort of philosophy here. Why it's worth to start innovation in Latvia? It's why not? My question would be, we are here really, I would say, very cross-functional and strong team to be able to deliver such a unique technology, and we have used all forces which we have here already for 7 years, and we made it happen due to our uniqueness, and why not? Yeah, why not in Latvia? So, but right now I would answer that we are a global company. Yeah, we are. Nowadays, it's not a problem to make collaborations between all kind of partners from anywhere. So, not only in Latvia. I hope I answered your question.
I think yes. Thank you very much, Madara Kalniņa-Kalmele, CEO of Lightspace Technologies, and wishing you well with innovations further. Thank you very much. Ladies and gentlemen, we are in, well, yes, why not say historical moment of the day, because we are switching to final panel discussion we're going to have here in the studio, which is bringing together the ideas that were shared together, the thoughts that were shared together, with the focus on empowering healthcare innovations, how to boost innovations in the field in a better way, and what are the conclusions to take also from the digital health strategy, which is under construction at this particular moment in the nearest future. Our participants, as before it was, one participant will be here live in the studio, and this is Aris Kasparāns, Director of the National Health Service. Waiting him here on the stage. You can easily come. We have only imaginary applause. If it would be like in a classical, good old-fashioned way, then the applause usually is in the background. Welcome, happy to have you here. Then in our online way, we have Kristaps Krafte, CEO of Vigo Health, back again on the stage. Hello. Ronald Zvartkrus, International Partnership, Lead Public Health, Topicus, also saying hello one more time. Karina Sotnik, Founder, CEO, World Upstart Corp. Hello and happy to have you here. And Sim Sade, Founding Partner, Health Founders, also online. Welcome in this afternoon, and thank you for your time and being here. And the moderator of the panel session, Sergey Yakimov, CEO, Longanises, happy to have you here, and all the hard task of getting messages, getting recommendations for decision makers, and leading discussion is in your hands, Sergey, now. Wish you well.
Thank you very much, Martin. Thank you very much. And am I thrilled to be here today with all of you. It is my pleasure and an honor to open this, last panel discussion for today. Arguably a very sensitive panel discussion with our tremendous lineup of speakers. Now, what I want to emphasize here is that all of you come from tremendously different backgrounds in one way or another, but then at the same time, we are essentially all solving the very same issue here, right? We are looking at how to bring innovation in healthcare, how to improve the quality of services in healthcare, and how to facilitate this, arguably the most important part of bringing the innovation into healthcare, and that is public-private partnerships, right? How do we get innovation to talk the same language with public stakeholders? How we get this off the ground? How do we sort of make it happen on the state level? Now, before we actually start, some of you might wonder what the public-private partnerships are. So I have offered a very, well, dry definition here, and that is the cooperation between public and private sector established for a fixed term to meet public needs. In other words, how do we improve population health? By improving the quality, affordability, and efficiency of healthcare system through private-public partnerships. So this here would be our topic for today. The outcome of this panel here is a very simple one, well, not a trivial one. We want to come up with the list of MVP features, and everyone knows, I think, on the panel what MVP is, right? MVP features for the state to implement, right? To be able to be in setting up these private partnerships. Thank you very much for being here. And with my first question, and to warm you up, I would like you to sort of kick back, relax, clear your mind, close your eyes, and provide me with this very holistic, very utopian view. In your own words, what are the ingredients of a successful public-private partnerships in healthcare? Which variables, well, key variables, should come together for state and private sector to speak the same language? I can see that Kristaps is actually ready to get us up to speed here. Kristaps, what do you think?
Wow, thanks, Sergey, for the introduction, and hi everybody. Hi again. I think that I think there's one answer. Communication. Communication is the cornerstone of any successful partnership. Whether it's a public-private partnership, a private-private partnership, whichever one it is, but it's the communication. That means, and I think I'm going back a little bit to my previous presentation, is to these parties to sit down at the same location at the same time and talk about the issues that needs to be solved. It's the communication.
Communication it is. Karina, what do you think?
Well, thank you so much for inviting me, first of all. I think there are actually multiple features that needs to be said. When we talk about public-private partnership in healthcare, usually the public part is the funding and how to implement the funding, but also who to give the funding to. And very often the funding goes into the places that are not necessarily places that practice what needs to be solved. So my solution will be, number one, is to give opportunity to innovators, practitioners who solve everyday problems. So if you can go to hospitals, if you can go to academic institutions and set up the right opportunities for those innovators to innovate with the public funding, then you might see really interesting results. So I would say create the right ecosystems at the right places with the right players.
Right, so far we have communication and essentially accessibility of public funding, isn't it? So yeah. Essentially direct accessibility, right? Right, moving on to people in the room here. Aris, what do you think?
Well, I believe that we heard excellent example previously from Mr. Martinson, and I believe that it should be really needs-driven. I do really believe that both parties should see the benefit, should see the benefit of outcome, should share the same goals, what we want to achieve with this partnership, and then I believe that we can communicate, we can find funding from the state side. Yes, I believe there will be other things that the other people will say, but I would stay with needs-driven.
Needs-driven indeed. Sim, you come from an accelerator, / investor background, isn't it? So you are essentially a founder for the organization that creates businesses in healthcare or helps to create businesses in healthcare. So what makes a perfect private-public partnership?
Yes, great to be here and welcome everyone. We at Health Founders work with early stage teams who operate at the intersection of data, technology, and healthcare. And one of our core principles is that in order to build sustainable healthcare solutions, it's not enough to focus only on technological innovation, but you also need clinical validation, you need regulatory understanding, and you also need a viable business model. So what we very often see with early stage teams is that they focus a lot on building their products, but often struggle with the clinical, regulatory, and business validation. So in that sense, I think there is a clear need for better private-public partnership model. In a way, technology is something that the startup can do themselves. But for clinical validation, obviously, you need a lot of collaboration with, let's say hospitals or other providers, because that's where the specialists are, that's where the data is. For regulatory readiness, working with different relevant regulatory authorities, for example. So yes, there is a clear need for public-private partnerships to facilitate early stage innovation. And the question is whether the system is ready for providing that access.
Super. Ronald, last but not least, you are bringing a very unique background here. So you are actually a representative for a company that has done, well, cross-governmental deployments, right? And that is something to congratulate. So what's your take?
Well, it's been said a few times today, so the whole concept of value-based healthcare, if you have a proper discussion with the public parties and the private party and the academics, for example, that has helped us a lot. And with this respect, we partner up a lot with Erasmus Medical Center, who has a very good modeling program on forecasting in cancer screening programs. So, but once again, so communication has brought a lot to us. So we have monthly meetups with different partners, partly from a technical perspective, but also on health outcomes, of course. So, and like the business case should also be valid, of course. But I would say the whole concept of value-based healthcare, working this out together and have proper alignment meetings with all stakeholders involved. So that has brought us a lot, both in the Netherlands as well as in other countries.
Tremendous. Well, that's it for our warm-up here. Before we dive into the main part of the discussion, a sincere willingness of mine is when you feel like being provocative, please be provocative. When you feel like saying what you actually think, please say what you actually think, right? So we are here to actually define the action points for the government, so there is no need to be overly smooth around the edges, if I'm making myself clear. So let's do a quick reality check here. So Kristaps, you have started a very important discussion here, and that is communication. Specifically the role of communication in the process of essentially merging private and public, right? So public needs with private innovation. My question here is, and we'll start from your end, obviously, you were the one to bring it up. Who's the one to articulate the need? So who is the one to be self-aware or aware of the problems that are there, to be the first one to make a step and say, well, this is something that needs to be fixing? Who out of two stakeholders?
Who out of two stakeholders? I think there's a lot of stakeholders, but I can speak from my experience.
Private or public? Private or public? So is it the private or the public sector?
Oh, it's, I mean, okay, so in our experience, that was the public sector, and more specifically the hospitals that are dealing with stroke patients every day. So before I started Vigo, I did research on stroke in 2 large hospitals, one in Copenhagen and one here in Riga. And when I reached out to a hospital in Riga, to Stradinj Hospital, stroke was presented as one of the key challenges that hospitals struggle with. The patients are many, they return, they oftentimes leave with bad complications, and there's so many of them that doctors don't know what to do with them. They have to discharge them with no clear path of recovery oftentimes. So that was the public institution that gave me the idea that, hey, this is a field where I want to work in. This is a field that has a lot of challenges. And then me, as a later private sector partner that has a company, that was for me like a light bulb moment that, hey, public institution is telling me that this needs work, so I'm ready to do the work. But yeah, so and I think it always has to be the public sector or the public in general. You know, we work a lot with patients in figuring out the patient's needs and helping to fulfill those needs. So I think it's always, it should, at least in my opinion, always come from the public, whether it's the public sector or the public as in individuals.
Right, so let's try, thank you very much, Kristaps. Let's try mirroring this with a bit of an overseas experience. Karina, so one of your areas of activity, right, is helping to commercialize innovation. And that is indeed, well, that involves working with public stakeholders as well, right, as very important validators for that innovation. So in your experience, who was the one coming up with the problem or coming up with, you know, admitting that the problem exists?
Yeah, so I realized listening to Kristaps that we might have a slightly different view of what public is and what private is. As you know, in the United States, almost every healthcare institution is private, right? And so to me, public is the state government, the federal government, the city government that can facilitate, assist, fund. But there are also organizations on a federal level, for example, like BARDA, which is the Bio-Advanced Research and Development Authority, that funds major health countermeasures, especially now with COVID, but before with sepsis and what's not. So to me, public is usually in my mind funding. The origins of every innovation comes in my mind from practitioners. And those are the researchers that comes from academic institutions. Those are nurses, doctors, engineers. So, it will be interesting to ask a panelist what their origin story is, and you will find that either someone had a grandma with a stroke and start working with a doctor, or it was a doctor that started innovating. So I think establishing the right priorities within the institutions that have the right incentives for the innovators to innovate, that I think is one of the most important ingredients there. And the public sector can facilitate it. For example, BARDA gives funding to accelerators that accelerate that commercialization process and can de-risk it for BARDA and BARDA's investment. So that's one of the examples I can give.
Well, this is tremendous. I mean, so far we actually sort of leaning towards the notion that, it should be the public sector, that should be self-aware. Aris, question to you, and it can be a very concise sort of one sentence answer if you want it to be. So, what do you think is one single most important or most effective channel of how public sector or a public institution can actually voice its need for innovation or call out sort of the call for the private sector to help solving, let's say, a healthcare problem or help innovate in the healthcare space? What is one single most effective from the public point of view channel?
Well, channel, it's a really tough question. I mean, we don't have like much experience with this at this point, but I would say that with what Kristaps started is the communication, direct communication, with private sector, expressing our need, like in, I don't know, by setting some financing programs, schemes, and then putting forward our needs or blank spaces, gaps. I don't know. Maybe the.
And I know you had one very successful example now with COVID, right? With National Health Service actually reaching out to the public sector. How would you evaluate that one? I mean, was it a landmark example for us? Is it something that we should do more often, that we should repeat as a standard practice?
Well, yeah, I believe, yeah. So what we actually did, we did call for help for private sector. There was a need to deliver patient data to the patient on regular basis, the data from pulse oximeters, so that the patient can follow his readings, and the general practitioner and family doctor can follow their readings and react more rapidly. And we call for help to the private sector, and we had two applicants that provided us with two solutions. We did finance them. We created testing opportunities. We deal with GPs, with general practitioners, and right now we're surveying this pilot project where we're asking general practitioners. So what do you think of those solutions? And well, yeah, that was a good experience, and I believe we will be working like this looking forward. Yeah.
Well, I think this is one very important takeaway, right? So it's exploring all the options, right? It's essentially not going through sort of your traditional procurement procedures, right? But rather sort of seeing what you have on the table in terms of maybe the innovation that can solve a real-time issue, or maybe a long-term innovation that can, transform certain areas of healthcare, and then exploring all options, right? And piloting all options, and well, funding all options as well. Coming to funding, so some of you have raised, specifically yourself, right? You've raised an issue of funding, essentially, and this obviously comes from your background, accelerating companies. So why don't you give us an insight into sort of the investor's mindset here? So in your work in Health Founders, when you are incubating companies, right? So when you're also financing companies sometimes in the very sort of pre-seed stages of their existence, is there a specific playbook, or is there a specific emphasis that you put on the need to actually validate their solutions with public sector? Are you emphasizing the public sector as a key stakeholder versus, you would say, well, if public sector doesn't follow, right, and if the drag is not there, well, just go and sell your solution with private stakeholders, and it's much easier, right? So what's your take on that as an investor?
Yeah, so we have actually adopted a specific framework for healthcare innovation that we use in our accelerator program. It's called the CIMIT model. It actually originates from US, but is today used quite widely in EU as well, in the EIT Health network, for example. And basically what this framework establishes is 4 domains that an early stage startup should pay in mind. Like I mentioned before, it's the clinical validation, the technological side, the regulatory, and the business model validation. And again, quite often these teams, they start off with focusing a lot on their technology side and not paying enough attention to the big picture. So this is where we can actually come in and help them build a more balanced roadmap. And with regards to PPP, I think that model is actually perfect for building those bridges between those early stage companies and public entities. Basically, the model pushes the teams to take steps and run experiments in all those 4 work streams simultaneously. And you could say that at least 3 of those four elements are directly kind of connected to different models of public-private partnerships. So clinical validation, obviously, regulatory, clearly, and the sort of business or reimbursement model as well. So by using that very structured way of helping teams build their business, we're actually allowing them to connect better with the ecosystem as well.
Well, this is very interesting. So coming back to US for a second. So what is your take on let's say spending early funding of startups? And this sort of funnels into my second question, and that is, does the company size matter? Right? So are we talking about small companies that are fit to work with public institutions, or you should essentially be a big organization, right? So in US, from the US perspective and from your sort of commercialization perspective, you know, how successful are these pre-seed invested companies or seed invested companies in actually talking the same language with state? Do they have the firepower? Do they have the admin resource to begin with?
I assume you direct this question to me, Sergey. So yes, I work with very early stage companies that come out of institutions, and they grow into a reasonable size companies. And so they need to have administrative power to work with hospitals, to work with governments. However, where I see the biggest bottleneck is they might work well within their own institution, but as Slim said, they need to show market traction, and that means going outside of their own walls and show validation with other institutions. And we sometimes find that institutions are not set up to take innovations easily. So hospitals are notoriously conservative, and we find that hospitals that don't have all the stakeholders at the table, a young company might spend a year in talks with a hospital only at the end to hear no.
Right.
And they just wasted a year on that, right? So getting all the stakeholders to the table, having the right innovation groups within the public institutions or private hospitals, I think is the key to adopt new innovation. And it can come from the same hospital or other hospital, but I think getting IT people on board, because sometimes they're the most conservative. They just spend, a year building proprietary system within a hospital, and suddenly a new solution comes in. So getting them to be open-minded, getting the chief innovation officer on board, all of this becomes really important for the young company to validate their innovation. And I just want to say one more thing. We see really interesting trend right now where hospitals start to share their data. They sort of create this data exchange programs that benefits everyone. And here in Philadelphia, we went a step further, and we developed sort of a sandbox for the young companies to play, to plug in their innovation to real patient data. Obviously, all the privacy laws are implemented to validate their technology. And that goes to something that Slim said, that you have to have go-to-market strategy, but you really need to validate your technology and show market traction with real data. And this type of environments where you can test it becomes really invaluable for young companies.
So what I hear is sometimes public stakeholders actually need to assume sort of the role of this first leap of faith with the young companies, right? Because they might actually, provided certain degree of flexibility is included, they might actually be the very first validators that will open up the doors for the company in the future, right? And I think we'll come back to that in a minute. So I think something like, well, the same thing happened with Kristaps and Vigo, right? Because this is where essentially your first validator was public health, right? These were public hospitals where you validated your product. Was that correct?
Correct. Yeah, we have collaborated with 9 institutions here in Latvia that have tested Vigo with the patients there. So for sure, that has been a big help in bringing Vigo to market. But hey, we're not yet. Yes, we are in the market, in a B2C market, but healthcare doesn't work like that. And Siim actually also mentioned very nicely that there has to be a business validation there, and we know where our business is, we know where our patients is, where our patients are, and that is they are in the public healthcare system. Their care is usually provided by the state. So we have the business case, and maybe I'm going to return to this later. We have almost nailed this part of our business proposal, but we still need that final. We still need to make that final step to get that government reimbursement, and that's maybe a question to Aris. Where is this in the priority list? Do we continue to fund? I mean, this is maybe a question, yes, to Aris, because he represents the NHS here. But do we continue to put the money into things that we have put into for a long period of time, but we don't know what's the return, or do we want to implement something that's very valuable but maybe new? It's yes, we have come a very long way, but there is still those last things to be done to really make sure that we deliver patient care that's of high value.
Right. I think we'll give Aris 3 minutes to think about that one. Okay. And I actually want to bounce back to Ronald here. Ronald, so with Topicus, you have implemented statewide projects across different geographies, right? Which is, I must admit, very impressive. As a person that did projects with states, right? It is very impressive what you did with Topicus. So my specific area of concern here is authorities being risk averse, right? And what you've dealt with was a very sensitive issue of screening, right? Or pre-screening of potentially terminal diseases, right? And that is a matter of national concern, obviously. So what were these most important sort of risk aversion mechanisms from public authorities that you have encountered, and how did you overcome them, right? So what were the bottlenecks, and how did you manage to get through the bottlenecks to begin with, right?
Well, then I think the example from Colombia is pretty nice. So where we are well into the early stages of introducing cervical cancer screening. There we had the counterpart of Erasmus Medical Center, Javeriana Universidad, which is a very well-known university in Bogota. And there some people work very closely together with Erasmus Medical Center, and they have all expertise on cancer screening. So my suggestion would be to partner up with a very, very trusted academical institution. Well, in this case, Javeriana Universidad in Colombia. And that has helped really a lot towards the National Cancer Institute in this case. So, and basically this is about trust building. So because Erasmus Medical Centers have they have a very well-known public health center on cancer screening. They have modeling. They can, as I also told in my presentation, they can really show what the effects are on costs, for example, health outcomes, but also, of course, on the costs for screening per participant, et cetera, and that has helped a lot in the discussion. The second thing, what helped a lot is health insurers. So I'm not very familiar with the situation in Latvia, unfortunately, not yet. So that will also come with Longenesis and other partners. But the discussion between the National Cancer Institute in Colombia and also the largest healthcare insurer, to have the business case, to really also know if we are going to introduce an organized cancer screening program, this will be the health outcomes, but also this will be the costs effects. So this will be the cost per participant in this case in Colombia. So I would recommend to take really the academics and health insurers in the whole conversation. At least that has helped us a lot in our experience. Same counts for the Netherlands, by the way. A lot of innovation is boosted by health insurers, and SMEs partner up with them, and then some will be very successful. There are quite a bit of examples in the Netherlands with working together with health insurers, having a successful introduction of population health or another solution in the healthcare space.
Well, this is very exciting. So, a buy-in from academia as one of the key stakeholders, sort of to lead the process and essentially pre-validate, right? It's pre-validate the solution that is being brought in by the public sector, saying, well, this actually makes sense, right? Scientifically or even technologically, is something to look out for. Let's trace back to one question before, and that is Kristap's the point you've raised on risk aversion, right? Of the public stakeholders, essentially in walking this last mile, right? With solutions or with treatments that have been already validated with public stakeholders. They sort of already have the pool of data around them, right? And that would like reasonably be the time when you would say, well, all right, let's implement this. But then the public stakeholders are very risk averse. So what is it's an open question, right? So what is your take on that, right? So what is your logic as a public institution in that regard when you are evaluating these, the data that was generated or the effect or the benefit of a certain solution on the society?
Mm-hmm. Well, I would raise 2 points actually before the evolution process. I would like to make clear. First of all, well, I have to admit that the whole environment regarding the public financing, public spending is very conservative.
That's fair.
It's far beyond the NHS, and it's like the whole system is such, and we have revisions, you have everything, and so well, the environment is really conservative. The second one, and I risk here being very repetitive and maybe sound unprogressive, but the second one, the second point is the lack of financing. Well, we know it's true in Latvia, the lack of financing in healthcare sector, but this problem actually is what it does for such new new things, new solutions. We don't have enough funding for existing healthcare services for existing technologies, and if you want to deliver new things in our market, we just don't have enough funding to take away from something and give something new. So if you want to do that, you see that the existing services are underfinanced. So that's the second point. Regarding the solution Kristaps is providing, this is actually this is actually the last mile, because we have evaluated, we have set tariffs actually for services WeO Health is providing. We just don't have the yearly funding available. So we are looking at actually different ways, and here comes the EU's resilience and recovery facility. So we hope to develop a program where we could test those new solutions, new services, new models, and then maybe we could prove that they're more effective than the existing ones and replace them.
Right. So, Kristap, I'm literally doing some business development for you here. So you see, it's in process, right? It's not there yet, but it's getting there. So let's talk about funding for a second here. So, Sim, again, investors' perspective, investors' mindset. When working with early stage companies that essentially are willing, and they're always willing, right? So when you're always early stage company, you still have this sort of fire in your eyes, and you assume that you will change the world, or at least half of the healthcare sector, right? At least half. So when working with these early stage companies that are looking to conduct the first pilots, let's say, or are pitching themselves as first pilot opportunities for the healthcare sector to the public stakeholders, what type of funding models, and it's a very specific question, right? So what type of funding models for these pilots you would be looking at as the most appropriate, right? Should the companies provide the first sort of, financial incentive and say, well, okay, we'll do the first validation with our own money because we have, received pre-seed funding and we're ready to contribute? Should this be a chip in, right? So some sort of risk sharing chip in from the state. What is maybe your view as an accelerator, right? As a founder for health founders, as well as maybe a bit of a general sort of Estonian perspective, if we're talking about how companies collaborate with state there.
Right. So I mean, from an accelerator perspective, obviously with early stage companies, they are all operating on a number of assumptions. And the key there is to sort of validate those assumptions as quickly, as efficiently as possible, without spending too much money, to be blunt. So we are thinking a lot about how to provide these correct tools and support for the teams to do that. There's a concept called Living Lab that we are sort of designing in Estonia. Health Founders is based in one of the largest smart city establishments in Northern Europe called Ülemiste City. And we precisely chose that place. It's 12,000 people, over 500 companies, a big health center, to help our teams validate their products in real life environments with real end users, patients, customers, doctors. So that's one way of kind of helping them to validate. In terms of other Estonian examples, in terms of collaboration with the state or government, one of the examples, last year, Estonian National Health Insurance Fund initiated a competition to find new innovative digital healthcare services, focusing on remote service models. So it was an open call. They got 33 applications from sort of existing service providers who had teamed up with different technology partners. And at the end, 4 projects were chosen that are right now in prototyping and development. And next year we'll sort of go into more in-depth impact assessment and market validation. And this is sort of funded by National Health Insurance Fund, which is a very sort of important and sort of landmark project in a way to send a message from the government as well to say that we are looking for these new solutions. And there are projects like this coming up more and more. So.
And how were these areas specifically defined? Were these independent KOLs that were defining these? Were they state agencies themselves that were defining the areas where they want to essentially see innovation? Where was the push coming from, right? Which stakeholders?
Yeah, I think the sort of the overarching kind of objective for this particular project came from the National Health Insurance Fund. So the areas and the topics were defined by them. The key idea was to find new remote service models, so digital health services, and it's their innovation unit that was in charge of that particular project.
Sounds good. Well, yeah, Karina, please.
I just want to add a sort of U.S. perspective to this. So, Slim mentioned the CIMIC model, which is a great model out of Boston, and many other countries adopted it. We know that there is now MIMIT in Manchester, UK, where they work with a national healthcare system that identifies, for example, 4 areas and pushes innovation into those 4 areas, and they get research institutions to create innovations and then immediately adopt it within this healthcare system, which is wonderful. But if you look at the numbers, that means that they created about maybe 4 or 5 companies out of that limit. I just want to counter it with a different system that we see here in the US. For example, just on the base of one university, University of Pennsylvania, some of you may know it because it's a home to Wharton School of Business, but it's also home to great medical school and healthcare hospital. And so their innovations come organically because the right incentives are set in. And it created over 200 companies in the last 10 years, has 68 companies in their portfolio because they set up the right structure to bring, and speaking of public-private, to bring business people and sort of create collaborations between business people and researchers, doctors, to create companies. So you can have both models, right? You can have healthcare pushes innovation for their specific needs, but you can also innovate within and inside and push it out into the marketplace if you have all the right components, like CEOs, business entrepreneurs, innovators within the research community, the right IT folks, and so forth.
Tremendous. I see Ronald has his hand up. Ronald, I actually wanted to switch to you with my questions now anyway, but please go ahead with whatever you wanted to contribute, and then I'll kick it off.
Okay. Well, I'd like to add the options from the EU. So there is, as a couple of hours ago, there was an interesting presentation that has 5 billion euros available altogether. We participate in a pan-European project with 3 countries, so Montenegro, Romania, and Georgia. And for an SME, it can be very, very interesting to join these kind of tenders, or at least, if you are very small, it's a bit more difficult probably. But I can really highly recommend these routes. So these are across nations. We do that together with the Erasmus Medical Center. We learn all those countries. We learn the health systems. We can validate the software in those countries. So I would highly recommend SME startup, early stage companies to try to get one of those tenders and to have immediately you have a very valuable network across nations. That would be my add-on.
Great. Siim, you had something to add? I saw your hand up.
Yeah, just another example came to mind with regards to sort of public-private partnership-based projects. Again, from Estonian experience, Estonian government fund SmartGap is actually preparing to launch a new deep tech program next year. They're right now doing a procurement to find an operator for that. And this is basically meant to commercialize deep tech-based health technologies. So a really unique program in the making right now. The idea is to accelerate or bring to market 15 projects in 18 months and kind of help them go from one TRL to the next. And at the same time, basically build a proof of concept model for this type of deep tech accelerated program. So that's going to be interesting as well.
Well, thank you very much for this. I want to drift into another topic, which is kind of sensitive as well, but it's very materialistic, okay? And that is the cost-benefit analysis of any sort of private-public partnership. And here I would want to interrogate 3 people in the room, and that will be Kristaps, and that will be Aris, and that will be most probably Ronald. Now let's start with Kristaps. So Kristap, you are a digital health startup, and you do have a cutting-edge solution, right? And it is great, right? It is great, and congrats on that. Why are you working with public stakeholders at all? Why aren't you selling to, private sector, right? Which seems to be easier, which seems to be faster, and well, in monetary terms, more successful at oftentimes. Why?
Okay, so two things. First, we work with the public sector, with hospitals and rehab centers, because that's where the practitioners are. And if we work, and if we have a medical solution, medical device, we cannot bring it to market without the support of healthcare professionals. That's why we work closely with them, educate them, and tell them about us.
Right.
The second point, we have to look at how the healthcare system is structured. In Europe, for the most part, the healthcare system is in a public domain. So whether it's a national insurance fund or it's a national health service like we have in Latvia, that is a public institution that is in a sharp contrast to the US, where most of these institutions are private. I am actually now in the US, and we are launching Vigo here. We've been here for now almost 2 months, and we are already closer to closing a contract here than. Well, no. In Latvia, we already have the tariff, and we have gone very, very far. But in the US, what we have done in 2 months, we perhaps did in Latvia in a year and a half. So yes, private sector is moving much faster, and we will have to also make a choice whether we just focus on the private sector, which yes moves faster and perhaps give us more money, or to focus on, which has always been so important to me. I moved back after almost 10 years of living abroad to do something good for Latvia and the ecosystem there, and I think we're super, super close. And so many people in Latvia have already used Vigo and recovered. But the road is longer and harder. So yes, it is a choice that startups make, whether to sell to public sector, which takes longer time, or to go somewhere else where the healthcare system is structured in a different way, and sell to a private sector.
Thank you, Kristap. And this is an important point that I was actually waiting for you to make. And that is this inevitable connection of a healthcare company, right? A healthcare services company with the public sector, right? Sometimes you cannot just abstain from working with it because your practitioners are there, your champions are there, right? And you are forced to deal with sort of, slower decision-making processes and evaluations and procurement processes, et cetera, et cetera. So you're somewhat trapped sometimes. But it's not all that bad. So Ari, coming back to you here, it is natural that public sector is sort of a slower mover than private one. It's okay. So how would you, in very simple terms, how would you articulate, the value and the motivation that a private company, let's say a private innovator, bringing whatever digital innovation in healthcare, for example, what will be the single biggest point of motivation for it to to still get out there and to pitch it to the public authorities and essentially go through that process. What's your subjective view on that? I mean, what is the single biggest motivation point there?
Like the motivation point for startup
for a private company to essentially engage with the public authority.
Well, I believe the answer, the question was answered already. In Europe, the public sector is payer for the healthcare,
right,
on the most part for the healthcare services. So this is one thing, and as Kristap said, I would not put it as a public sector as such, but the hospitals, the clinics, where the most of specialists are publicly owned, the biggest ones, the clinical university hospitals. So I would like to separate the like public authorities such as NHS that I'm representing and hospitals as such, but they are publicly owned, and the purchaser of health services is NHS. So I believe that's really the biggest motivation here, as Kristap's already mentioned. Yeah.
I also, Kristap, just one sec here, right? So are there any shortcuts for, in certain disease areas or in certain sort of domains, are there any shortcuts to to bring your potential collaboration with state or with public authorities closer? Is there a cheat code?
Cheat code? I wouldn't call it a cheat code, but
a shortcut.
A shortcut, yeah, really. We had this big crisis, this need, and we started it. I started it with your first question with the needs from the public side, and the COVID put forward one big need. So we had really short time to pitch those solutions that I previously talked about. Well, I believe that this needs, the public needs, in desperate needs, I don't know, at such times as these. So we can move much faster when there is really a pressing need.
Sounds good. Christoph, you had a question.
I had a comment. So your
Great.
question was about motivation. And I think what's missing here, Aris briefly touched upon the conservativeness of the industry, and it's totally right. And Aris works with so many constraints. I think what's missing in the motivation is, or at least what I'm not seeing fully, is the political will. I've heard so many talks and conversations about supporting digitalization, supporting information communication technology, supporting value-based healthcare. But I don't see this on the top of the priority list politically. What's on top of the priorities right now is COVID. And I think I go back to my presentation a little bit. We should stop seeing, or COVID is crisis, no doubts about that, but we should already solve it. And by solving the crisis with some of the opportunities that are presented, we will solve not only the COVID-caused crisis, but also long-term healthcare challenges. So I really, really are looking for this, more of this value-based aspect, more on this value-based aspect that then can improve the private and public-private partnerships. Because there are companies like Vigo, but there are many companies that provide digital health value-based solutions that don't get to bring their solutions to the market. So we are ready. We just need this, in my opinion, more of a political push. Maybe there's some other aspects there, but this is one that came into my mind.
Excellent. So this comment here actually makes me shift sort of the discussion strategy a bit. And what I want to talk about here, and this is sort of a question to all, right? What I wanted to talk about here is this asymmetry between the big goals that, the management, essentially, the visionaries are setting, right? And well, these can be politicians. For those of you who have worked with corporate, these are CEOs of the companies that say, well, the innovation is the goal now, right? So we need to innovate. But then the issue always is, you need to drop down this vision to the actual, well, people, right? To the actual employees or to the champions within the organization. And this is where it gets stuck very often, right? So at most times, the issue is maybe the vision is there, but then the implementation is sort of very laggy. And I want to start with Ronald here. So Ronald, in your encounters with state, right? You always had the big vision of the ruling party or whatever that was, right? So the lead that was in favor of implementing screening services or whatnot. How did you overcome this barrier of actually dropping it down to the actual performers, right? And how did you manage to push it through? Because that is often the bottleneck.
Yeah, well, that is a very, very interesting question. What helped us a lot is to have to talk with. It's a little bit a cliche. I don't mean it this way. To talk with the right people, so the ambassadors, so the people from the academics and politicians who are really, really with their heart in the healthcare. And for example, with cervical cancer screening in our case, or breast cancer screening in different counties, there are, in this case, most often women, extremely enthusiastic, so both on the politician side, but also from the academics. And this has helped us a lot, together, of course, with such a trusted party like Erasmus Medical Center. So within this whole arena from politics, there are certain persons, and you have to identify those certain persons. And if you are lucky, they are also some kind of a key opinion leader. So that would be make a very precise analysis of with whom am I going to talk. So who are the influencers, and these are the most enthusiastic people. That's what we see in different countries. So that's what I would say, make a qualitative analysis of the persons in different levels from public side, but also like health insurers, same thing counts for them. So that would be my suggestion.
Sounds good. Karina, what about the US perspective? I mean, how do you deal with this sort of, visionary performer gap, if I may? Is it, a more, say, horizontal structure of decision making in public authorities? Is it what? So how do you deal with the issue?
Yeah, I think you're right. Innovation is such a buzzword. Everyone is using it. There's a corporate innovation. There is innovation being pushed in all sorts of places, including academia. And I'm speaking with the experience of driving innovation from academic institutions, from universities. I think it's really important to set the right incentives. 10 years ago, researchers were evaluated on how many papers they published, how many conferences they speak on. If you switch that incentive a little bit into maybe IP creation and then startup creation, and if you build the right program to help those researchers along the way, success breeds success. And then, if your colleague suddenly is the, co-founder of a great startup that is, and has great equity in it, suddenly everyone wants to innovate. So it's setting up the right priorities. I think finding the right key opinion leaders for your small startup becomes really important. And one of the things that my company does, we help international companies to come to US market. And because we're so connected to various academic institutions here, I always advise companies, find that key opinion leader within US academia and bring them to your board. Board members can do wonders for a young startup. So that would be my strategy. As Ronald said, KOP, bring them to your company and validate through academic institutions. At least here in the US, this is the way to go.
Right. So we're now coming to the end of our panel here, and we essentially have two questions left. But before that, Ari, so very quickly, what is your strategy of dropping the innovation down at performers within the organization? Right. You've mentioned a few cases that at COVID, for example, you recently had. So what is your strategy of communicating, the need down to the other layers of the organization? Is it the internal strategy where you are communicating it internally, or you are attracting KOLs from the outside, sort of to push it or to articulate it? What is your take at the National Health Service?
Well, the first strategy is actually always selling the idea to your personnel, and I believe we are sharing the same thoughts in NIHS on the projects where we see the clear need for it. But well, as you said, this is a big problem sometimes to sell the idea, and there's also a lack of internal resources. But one takeaway from today actually would be don't try to do it all. Speak, communicate with private sector and collaborate to push things forward.
Right, so essentially the state should not be the innovator, the state should be this fast and grateful learner in a way, right? Absorbing the innovation and looking around rather than coming up with something. Well, that's actually a very good punchline to conclude today. My last question to everyone, and I want like a very, very concise one-sentence answer. So we need one actionable from each and every one of you, one actionable takeaway. What is the MVP feature, one MVP feature, for the state to master in order to boost the amount of private-public partnerships in healthcare innovation? One MVP feature that the public sector should have. Let's start with Kristaps.
Putting me on the spot here.
Yeah.
You know, if only I only wish for value-based and digital health solutions to be put a little higher in the priority list. I'm not sure if that's an MVP. I mean, you always by setting the by setting the features that go into MVP, you set priorities. So I just want the priority of digital health solutions and value-based solutions to be higher up.
Tremendous. Karina.
Well, there are many stakeholders in innovation, right? So it's really hard to create one sort of piece of it, but maybe to today's panelists, I would say create the right incentives for innovation so that every piece of that puzzle knows their incentives and works together to innovate.
Thank you very much for that, Siim.
Yeah. One thing, adopt the mindset of rapid experimentation and make sure the up-and-coming young companies have access to all the resources to do that.
That one is tremendous. Ronald.
I would plot the value-based healthcare concept on the business campus model, having different kind of end users in mind, and talk about this with the different stakeholders involved. So to make value-based healthcare really very concrete.
Superb. And Ari, to conclude.
Just as I said previously, the last one, or as you added, be the fast learner, communicate, and don't try to do everything on the state side.
Well, superb. On this positive note, I would like to thank all of you today. I think it was a tremendous discussion. I think it was an open one, and we do sincerely hope for the action items that were voiced today to be actually implemented in real life and in digital strategy to come. So thank you very much. I appreciate those of you who had time to connect virtually. I appreciate, Aris, your time. I know it's a tough time for the National Health Service for being here. Thank you very much, and we'll hopefully see you one day in person. Thank you.
Thank you very much to all.